Laryngospasm is the prolonged closure of the glottis. It is an exaggeration of a protective reflex that helps to prevent aspiration. Laryngospasm more commonly occurs in children compared to adults. Common signs are stridor and paradoxical chest movement due to respiratory effort by the patient, but inability to move air across a closed glottic opening. Differential diagnoses include bronchospasm, supraglottic obstruction, and breath holding. The risk factors for laryngospasm can be categorized into 3 types: anesthesia-related factors, patient-related factors, and surgery-related factors. Anesthesia-related risk factors include stimulation of the patient or direct stimulation of the vocal cords by blood, mucus, the presence of a nasogastric tube, suctioning or laryngoscope blade during a light plane of anesthesia. Studies have shown that the use of inhalational agents increases the risk compared to IV anesthetic agents. Multiple attempts at intubation or LMA insertion increase the risk. Another risk factor is less experienced or non-pediatric anesthesia providers. A patient-related factor is young age. Laryngospasm is 3 times more common in younger children compared to adults, and 2 times more common in older children compared to adults. The risk for laryngospasm is increased during acute respiratory infection and up to 6 weeks after resolution of the infection. Certain types of surgery predispose patients to higher risk for laryngospasm. Those surgeries include otolaryngology surgeries, especially tonsillectomy and adenoidectomy, plastic surgery, appendectomy and hypospadias repair, bronchoscopy and endoscopy, and thyroid surgery. The mechanism for laryngospasm is the lack of inhibition of glottic reflexes due to inadequate central nervous system depression and increased stimuli of the vagus nerve during light anesthesia. Laryngospasm can be complete or partial. In the case of complete laryngospasm, there will be chest movement but no ventilation. During partial laryngospasm, there is partial closure of vocal cords, but air still passes through the posterior commissure, so there is stridulous noise and a mismatch between respiratory effort and air movement. Treatment of laryngospasm starts with first removing the irritating stimulus, such as secretions, oral airway, or laryngoscope blade. The next step is to apply continuous positive airway pressure with administration of 100% oxygen. This technique works well during partial laryngospasm, but will not work for complete airway obstruction and can result in insufflating the stomach. If laryngospasm does not resolve with CPAP, the next technique to try is the jaw thrust maneuver. The jaw thrust maneuver works because the vigorous forward pull of the mandible lengthens the thyrohyoid muscle and unfolds the supraglottic tissue. Another maneuver to try is called the Larson maneuver, which is firm pressure at the laryngospasm notch, which is located slightly cephalad to the earlobe between the mastoid process and the mandibular condyle.
Laryngospasm, a common complication after extubation, can be treated by the Larson maneuver. To perform the maneuver, first locate the laryngospasm notch behind the lobule of the pinna of each ear, anterior to the mastoid process of the temporal bone, and posterior to the ascending ramus of the mandible. Press the middle finger firmly on the notch in a cephalad direction. Some degree of jaw thrust may also be applied.
If laryngospasm does not resolve with CPAP or jaw thrust maneuvers, the next step is to deepen the plane of anesthesia with propofol. The intravenous dosing is 0.25 to 0.8 milligrams per kilogram. If the patient does not have intravenous access, or if deepening the plane of anesthesia does not break the laryngospasm, you can administer succinylcholine. The intravenous dosing is 1 to 2 milligrams per kilogram, and the intramuscular dosing is 4 milligrams per kilogram.
Note that if succinylcholine is contraindicated, you may use rocuronium at 0.9 to 1.2 milligrams per kilogram.
Succinylcholine may cause bradycardia and require treatment with atropine, 0.02 milligrams per kilogram for intravenous and intramuscular dosing. After giving propofol or succinylcholine, you will need to manage the airway by providing mask ventilation, as the patient will be apneic and probably already desaturated. Reintubation may be necessary if the patient is hypoxic.
Note that severe hypoxia or hypercarbia may terminate laryngospasm, but we want to avoid potentially life-threatening complications by intervening early.
Given the potential dangerous complications, how do you prevent laryngospasm? First, correct modifiable risk factors such as waiting 6 weeks from upper respiratory infection before proceeding with elective cases, or decreasing smoking exposure. Second, ensuring adequate depth of anesthesia prior to IV placement and other stimulations such as laryngoscopy, LMA attempts, suctioning, and placing oral airway can also prevent laryngospasm. Using a muscle relaxant for intubation decreases the risk for laryngospasm. Giving positive pressure breath while removing the ET tube decreases adductor response of laryngeal muscles, and it is also followed by a forceful exhalation that helps clear the airway of secretions. Lidocaine, either administered intravenously or topically directly on the cords, is controversial. Giving magnesium is also controversial. The proposed mechanism of action is smooth muscle relaxation and deepening the anesthetic.